What did surgery feel like before anesthesia? Part 1. London, 1842. Put yourself there. 3 days ago, a cartwheel crushed your lower leg. The bone tore through the skin, your boot filled with blood, and now the wound has turned dark around the edges. It smells sweet, then rotten. The surgeon looks at it for less than a minute. He does not order a scan. He does not call another specialist. He wipes his fingers on a stained cloth and gives you the only two options available. The leg comes off tomorrow morning, or the infection reaches your blood, and you die before the week is over. That was the math of surgery before anesthesia. You did not climb onto an operating table because your knee hurt, or because a small lump might become dangerous one day. You went because the thing inside your body was already trying to kill you, and sometimes people still refused. They chose the infection, the blocked bladder, or the crushed limb slowly turning black. Not because they were foolish, but because they knew what the surgeon was about to do. He was going to save your life, while you were awake for every second of it. Part 2, the night before. You say yes. Then you spend the night listening to footsteps in the corridor and wondering whether choosing surgery was simply choosing a faster death. By morning, your mouth is dry. Your hands will not stop shaking. Two assistants lift you because your injured leg can no longer carry you. They take you upstairs. The operating theater sits near the top of the building beneath a skylight. Surgeons need daylight. Electric surgical lamps do not exist, and neither does privacy. The word theater is literal. Wooden galleries rise around a plain table in a horseshoe. Medical students pack the benches shoulder to shoulder, leaning forward for a better view. Some whisper, some stare. One of them may pull out a pocket watch. They are here to learn. You are the lesson. The table is scarred and darkened by the people who came before you. Under it sits a fresh box of sawdust. You understand immediately what the sawdust is for. On a nearby tray, metal instruments catch the light. Knives, hooks, forceps, a bone saw. The surgeon enters wearing a dark frock coat stiff with old blood. The stains are not hidden. In that world, a heavily stained coat can look like proof of experience. You wanted the best surgeon in London. Apparently, the best surgeon arrives wearing parts of his previous patients. Part 3. The era's painkillers. Someone gives you a glass of brandy. You drink it too quickly. If you are lucky, you may also receive opium. Perhaps a leather strap is placed between your teeth. Perhaps a cloth is tied over your eyes so you do not have to watch the blade come down. None of this is anesthesia. Alcohol can make you dizzy. Opium can dull fear and soften pain. A strap can protect your tongue when your jaw clenches, but the knife will still feel like a knife. Humans had searched for surgical pain relief for thousands of years, using alcohol, opium, mandrake, and other plants. The problem was control. Too little, and you remained awake. Too much, and you might stop breathing. So surgeons relied on the only painkiller they could measure with confidence: speed. The faster the blade moved, the sooner the pain ended. That did not make surgery painless. It made agony shorter. Part 4. Your body does not care that you agreed. The assistants place you on the wooden table. One grips your shoulders. Another controls your hips and good leg. Someone holds the damaged limb straight. You tell yourself not to move. You agreed to this. You know the surgeon is trying to save you. Your body does not care. The thinking part of your brain understands medicine. The older part understands only that strangers have pinned you down and a sharp object is approaching your skin. Escape. That command is older than language. When the first cut begins, muscles tighten before you can stop them. Your back arches, your hands grab at the table, your healthy leg kicks. The assistants press harder. Patients did not fight because they lacked courage. The nervous system is designed to pull the body away from damage. Now imagine that reflex spreading through your entire body while several men prevent you from obeying it. The surgeon is fighting the disease. The assistants are fighting you. And you are fighting an ancient survival system that has suddenly decided the surgeon is a predator. Part 5. The fastest knife in London. This is why Robert Liston became famous. Liston was tall, powerful, and terrifyingly fast. He could remove a leg in a few minutes. Students crowded the gallery. Pocket watches opened. The blade flashed. Skin was cut. Muscle divided. The saw bit through bone. Blood vessels were tied before the patient collapsed. When both hands were busy, Liston was said to clamp the bloody knife between his teeth. Today, that image looks insane. In his world, it looked efficient. Every extra second meant more screaming, more movement, more blood loss, and more risk that the patient's body would simply collapse. Speed was not a performance trick. Speed was mercy. But speed had a price. One famous story claims Liston cut an assistant's fingers while a spectator died from fright, creating history's only operation with a supposed 300% mortality rate. Historians doubt it happened exactly that way, but the legend captured the terror of the system. The surgeon had to move faster than pain, but not faster than control. Part 6. The people who remembered. We know what surgery felt like because some patients survived and wrote it down. In 1811, novelist Fanny Burney underwent an operation to remove a diseased breast. She was placed on a bed. A thin cloth covered her face. Through it, she could still see the movement of people and the shine of polished steel. Then the blade entered. Burney later wrote that she began screaming and did not seem to stop throughout the incision. She felt the cutting, the pulling, and the instrument working close against bone. She fainted, then woke up while the operation was still happening. Even fainting could not rescue her. She woke to the same hands, the same room, and the surgeons still working. Years later, writing about it could still make her ill. Scottish chemist George Wilson survived an amputation before anesthesia and remembered the experience with terrible clarity. He heard the instruments being arranged. He felt the tourniquet twist tighter. He felt the first cut. He even remembered the handling of the freshly sawed bone. But his most powerful description was emotional, a black whirlwind of darkness, abandonment, and despair. Extreme pain does not stay inside the body. It takes over time, trust, and the feeling that other human beings are still on your side. Your body may leave the table. Part of your mind may not. Part 7. Why death sometimes looked better. This is why patients sometimes refused. A surgeon might explain that the diseased limb had to come off. The patient might understand every word, agree that death was coming, and still say no. From a modern hospital bed, that sounds irrational. From a wooden table covered in old stains, it makes perfect sense. You are not choosing between living and dying. You are choosing between a slow death from infection and a violent attempt at survival that might kill you anyway. The knife could also reach only certain problems. Surgeons removed limbs, drained abscesses, extracted stones, and cut tissue near the surface. Complex surgery inside the chest, abdomen, or skull required time and precision an awake patient could not provide. Pain did more than torture patients. It placed a wall around medicine. Then came the crueler twist. Even if you survived the operation, the surgeon might have already killed you without realizing it. Part 8. The surgical stink. Nobody in the operating theater knows germs exist. The surgeon's coat is stiff with dried blood. Instruments are wiped, not sterilized. A sponge cleaning your wound may have been inside another patient earlier that day. Hands move from corpses to living bodies. No one sees a problem. The smell of the wards is so familiar that people call it the good old surgical stink. Then, several days after your operation, the wound becomes hot. Your fever rises. Pus appears around the stitches. Some doctors are pleased. They call thick pus laudable, believing it may show that healing is progressing normally. It is not healing. It is infection eating through the work the surgeon just completed. This was the second round of old surgery. First, survive the knife. Then wait to see whether something invisible entered the wound. The surgeon could cut perfectly and still carry death on his hands, coat, sponge, or instruments. The blade was visible. The real killer was not. Part 9. The doctor who looked at the hands. In the 1840s, Ignaz Semmelweis worked in a Vienna maternity hospital with two clinics. One was staffed mainly by doctors and medical students. The other was staffed mainly by midwives. The doctors had more formal training. Their patients died more often. Semmelweis searched for an explanation until he noticed what medical students did before entering the maternity ward. Autopsies. They handled dead bodies, wiped their hands, and went directly to examine women in labor. Semmelweis ordered them to wash with a chlorinated solution. The death rate collapsed. It should have been simple. Wash your hands. Stop carrying death between patients. Instead, many doctors felt insulted. The idea suggested that respectable physicians were not simply failing to save patients, they were helping to kill them. They did not need a heroic new machine. They needed soap, chemicals, and humility. Semmelweis was mocked, resisted, and pushed aside. Human beings love evidence when it proves we are clever. We become much less scientific when the evidence points at our own fingers. Part 10. The morning the room went quiet. Then, on the 16th of October, 1846, a young man named Gilbert Abbott entered an operating theater at Massachusetts General Hospital in Boston. He had a tumor in his neck. The gallery was full. Surgeon John Collins Warren stood ready with his instruments. Dentist William Morton arrived carrying a glass inhaler filled with ether vapor. Abbott breathed from the device. His eyes closed. His body became still. Warren made the first incision, and the theater heard something almost unnatural. Silence. No scream. No leather strap grinding between teeth. No assistants straining to pin the patient down. No desperate hands clawing at the edge of the table. Just the quiet sound of a man breathing while a surgeon cut into his neck. When Abbott woke, he reported little real pain. Warren turned toward the stunned gallery and declared, "Gentlemen, this is no humbug." For the people in that room, one of medicine's oldest rules had just broken. The knife no longer required consciousness. Part 11. Why people resisted a miracle. News of ether crossed the Atlantic quickly. Robert Liston soon used it during a leg amputation. Out of habit, he still finished with astonishing speed. The patient woke up and asked when the operation would begin. Imagine spending your career cutting through screams, then watching a patient wake and ask whether you had started. You might think every surgeon celebrated. Some did not. Certain doctors argue that pain stimulated the body and helped it survive. Others believe that enduring the knife proved courage or masculinity. Some religious critics believe suffering had meaning and should not be removed. Pain had been unavoidable for so long that people built stories around it. Pain made you strong. Pain proved character. Then ether suggested something uncomfortable. Maybe pain was just pain. Resistance weakened. As anesthesia spread, in 1853, Queen Victoria used chloroform during childbirth. Once the Queen of England had chosen relief, it became harder to explain why everyone else needed to experience agony for personal growth. Part 12. The Two Revolutions. Anesthesia did more than stop screaming. It gave surgeons time. An unconscious patient could remain still. A surgeon could slow down, inspect carefully, and enter parts of the body unreachable during a 2-minute fight against panic. Surgery could move deeper into the abdomen, chest, and brain. But anesthesia alone could not defeat the surgical stink. That required the second revolution. In the 1860s, Joseph Lister began using carbolic acid to clean wounds, instruments, and the surgical environment. Infection rates started to fall, and the invisible enemy became harder for medicine to ignore. The two changes worked together. Anesthesia gave surgeons time. Antisepsis gave patients a better chance of surviving what they did with it. Without anesthesia, surgery stayed fast, shallow, and brutal. Without infection control, deeper surgery simply gave bacteria more places to enter. Medicine did not need one miracle. It needed two. One to silence the pain. One to stop the silence from becoming permanent. Part 13. The miracle you will probably complain about. Tonight, somewhere, a patient will lie beneath bright lights while masked strangers prepare to open their body. Their heart will race. Their mouth will go dry. Every ancient alarm system inside them will recognize the scene. Pinned down. Sharp tools nearby. No escape. Then someone will place a mask over their face and ask them to count backward from 10. 10. 9. 8. Maybe 7. The room disappears. Hours later, they wake beneath a clean blanket. The wound is closed. The damaged organ is repaired. They remember none of the cutting. They may complain about the hospital food. That is what happens when a miracle becomes ordinary. Fanny Burney remembered the blade. George Wilson remembered the saw and the feeling that the human world had abandoned him. You will probably remember a countdown. That is the distance between their operating table and yours. Not better courage, not stronger bodies. A few discoveries accepted slowly after generations of patients paid for them in pain. For most of history, surgery could save your life only by forcing you through something that felt like death. Now you close your eyes at 7 and wake up on the other side.